but it gives me great pleasure to first of all introduce Dr. Giuseppe Lombardi from the University of Padua. He is a medical oncologist who trained in Padua before doing fellowship stints in Memorial Sloan Kettering in New York and also in Paris, and is a real expert in the field of genomics in high-grade glioma. We are very excited to have Dr. Lombardi here today to give us his talk. And Dr. Lombardi, if you don't mind sharing your screen, we look forward to your talk on targeted therapy in neuro-oncology.
Okay, good afternoon, everyone. Many thanks for inviting me, Professor Gleeson, to these very interesting seminars on neuro-oncology field. So I'm sharing the screen. Okay. 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 This. Okay. Okay, good. So my talk is on target therapy in neuro-oncology field, and where are we and where are we going in this way. So this is my disclosure. And so we know that target therapy is a specific treatment using drugs that target specific molecular alterations involved in the growth and the survival of tumor. And so in this way, we can better select patients and to use a specific treatment for a specific patient based on molecular characteristics. We know that target therapy is an important treatment in a lot of types of tumor. But now we have a target therapy also for neuro-oncology field. In particular, vorasidenib is the first drug demonstrating efficacy in a randomized phase 3 trial in brain tumor, in particular in low-grade glioma with IDH mutation. We know that IDH mutant gliomas are characterized by mutation of IDH1 or IDH2 enzymes, and so they show enzymatic capacity to convert alpha-ketoglutarate into 2-hydroxyglutarate that is considered an oncometabolite because it can interfere with many oncological pathways. And very important is that this mutation is represents the first step of gliomagenesis, and so it's very important to inhibit this alteration, this function, as soon as possible. Some years ago, vorasidenib and other IDH inhibitor, ivosidenib, were analyzed in a perioperative phase 1 trial analyzing low-grade glioma. I think that it's a very important study because the authors analyzed the efficacy and the molecular alterations due to IDH inhibitors into the glioma cells. And in this study, patients were treated with vorasidenib or ivosidenib, and then tumor blocks were analyzed during or after the treatment by a second surgery. And very important is that in these patients, and in particular in glioma cells, a patient treated with these drugs reported a lower level of 2-hydroxyglutarate comparing to the external control. And also on MRI analysis, the authors showed that also the size of the lesion was reduced. And so this was an important study, demonstrated for the first time the potential efficacy of these two treatments, both on molecular characteristic and also on MRI assessment. And so it was performed the Indigo study, very common, very famous study. It was a phase 3 randomized study analyzing the low-grade glioma patients, in particular with low-risk patients. And they were randomized with vorasidenib or placebo. The primary endpoint was progression-free survival. Secondary endpoint was time to next intervention. And so we know that the primary endpoint was met, and the progression-free survival was longer in patients treated with vorasidenib, and also the time to the next intervention. So about safety, the vorasidenib demonstrated a manageable safety profile, and we can see that only 3.6% of patients discontinued the treatment due to adverse events related to vorasidenib. And this study changes the treatment of low-grade gliomas, because we have a new treatment we can use in this setting of patient, in low-risk, low-grade glioma patient. And so these patients will be treated with vorasidenib and not longer follow up during the after the surgery. And so it's we have another important study published recently on cancer cells, and the authors demonstrated, analyzing patients with IDH mutant oligodendroglioma, that IDH inhibitor can change the molecular characteristics. In particular, we have an increase of astro cell after IDH inhibitor treatment, and a minor number of stem-like cells and oligo-like cell in patients treated with IDH inhibitor. And another important message of this trial, this study, is that in patients with NOTCH1 mutated, we can have a minor number of astro-like cell in this setting. And so maybe this mutation could be inhibit the IDH inhibitor, and it could be a new biomarker of efficacy for IDH inhibitor. And so the question and the next step on vorasidenib are if vorasidenib could be efficacy also for grade 3 IDH mutant glioma, if we have a potential association with the standard chemotherapy, and if we can use vorasidenib also in patients with low-grade glioma already treated with standard treatment, radiation therapy or chemotherapy, and now they are in stable disease. And if we can have a biomarkers of vorasidenib efficacy like Notch1. Moving on to another tumor, diffuse midline glioma with H3K27M mutation. We know that we can have a new potential treatment for this tumor. We know that this tumor is a very aggressive tumor. It's classified as a grade 4 glioma, and now we have not an efficacy treatment for this tumor. In the last year, it was analyzed a new treatment called ONC201. It is a DLP2 antagonist. It is a receptor for dopamine, and it is involved in a lot of intracellular pathways. And recently, it was published on JCO, a prospective study analyzing this treatment in recurrent patient with this tumor, where included 50 patients from 5 different prospective trials. And all of these patients had a recurrent tumor, and the result was very impressive because we have an overall response rate of 30% with a disease control rate of 44%, and these results met primary endpoint of this study. And we have also an important response on clinical condition in these patients, because about half of patients reporting a response to this treatment had also a decrease in corticosteroid use, and also an increase in performance score in 20% of the cases. And after these important results, now we have the possibility to enroll patients in a phase 3 randomized trial called ACTION trial, where patients with this tumor will be treated with ONC201 or placebo after radiation therapy. Another important aspect of target therapy is the agnostic treatments, because we can use a specific treatment against a specific mutation present also in other types of tumor. And in particular, we have BRAF and NTRK mutations. We have this BRAF mutation in about 4–10% of gliomas, and NTRK mutation in about 1–2% of glioma in adult patients. And BRAF inhibitors were analyzed in the ROAR trial, analyzing both low-grade glioma and high-grade glioma patients. It was a basket trial. And we have an important results with overall response rate about 30% in patients with high-grade glioma, and 57% in patients with low-grade glioma, with an important median duration of response. Indeed, it was longer than 36 months. So most of the patients were heavily treated patients, and I think that it was an important result also in this context. This is our patient treated with dabrafenib and trametinib, combination of BRAF inhibitor, reporting a durable response after 4 years from starting treatment. It was a patient with recurrent glioblastoma. But important is that maybe this treatment could be used as first-line treatment. Recently, it was published on New England Medical Journal an important randomized study analyzing pediatric glioma treated with dabrafenib, trametinib, or standard chemotherapy. And in this context, the experimental therapy demonstrated better results, both in terms of overall survival than overall response and progression-free survival. And another important study analyzing a proteogenomic characteristic of glioblastoma, in particular in recurrent glioblastoma, demonstrating that most of these patients had a neuronal transition during recurrent disease, and in particular it was improved by BRAF activation, and so it could be useful to use this inhibitor in combination with temozolomide, also in as first-line setting, also in adult patients. Another important treatment is NTRK inhibitor, such as larotrectinib. We had a prior study published some years ago, and this year at SNO Congress was presented the update of this study. 41 patients treated with drug were analyzed. The primary endpoint was the overall response rate. We can see that the overall response rate was higher in pediatric population, in particular in low-grade glioma pediatric population, with 57% of overall response rate. In the adults, we have only 15 patients reporting an overall response rate of 8%, but very important is that most of these patients reported a stable disease and not a shrinkage of the lesions. And in these patients, the duration of response was longer than 10 months. And maybe radiological response could be not the right endpoint in these patients, in my opinion. Entrectinib is similar to larotrectinib, but is also target ROS1 fusion or ALK mutation. It was presented in another study, prospective study, analyzing the pediatric population with an objective response rate of 50%. And in this study, we had also 3 patients with the glioblastoma reporting an interesting results with a disease control rate of 100%. Moreover, we have a study comparing entrectinib and larotrectinib as pharmacokinetic and pharmacodynamic, and the authors reported a higher concentration in the brain in patients treated with entrectinib, and maybe it could be more efficacy for these patients. We had a glioblastoma patients with ROS1 fusion treated with entrectinib, reported a long response over 1 year from starting the therapy. Another important mutation is FGFR. It is it was analyzed in about 16% of patients enrolled in the basket trial called Ragnar trial, and the first results were presented this last year at the SNO Congress. And in this study were analyzed 30 patients with high-grade glioma and 7 with low-grade glioma. Primary endpoint was overall response rate. In low-grade glioma, we had important results with a disease control rate of 71% and an overall response rate of 28%, while a minor results in high-grade glioma with an overall response rate of 10% and disease control rate of 56%. However, the data are not mature until now, and so we are waiting for the final results. Another similar study is FIGHT 209, and the enrollment was concluded, and we are waiting for the final result also for pemigatinib, another FGFR inhibitor. Other inhibitor is MET inhibitor. We have some clinical trial ongoing, such as Sparta clinical trial. I would share with you our case treated at our institution with MET inhibitor and MET fusion, reporting, and this patient had recurrent glioblastoma, and we treated with this MET inhibitor, reporting an excellent response after 2 months from starting the treatment. However, what is the implication of target therapy in glioblastoma in clinical practice? We analyzed that issue in a recent study, analyzing 470 patients with glioblastoma, analyzing with NGS panel, and we demonstrated that about 80% of patients can have at least one actionable alteration, but only 3% of that had alteration classified as SCAT 1B and 1C. And however, from 400 patients, only 9% of patients corresponding to 36 patients received a target therapy in our population. Mostly were lost due to clinical deterioration, almost half of them, because I think that the request of NGS was done when the patients was already in clinical deterioration. And we treated patients with different targeted therapies, but we can see that only response were seen in patients received a BRAF inhibitor, only 1 patient treated with entrectinib. And we analyzed also the progression-free survival ratio between the progression-free survival of target therapy and progression-free survival of the prior treatment. Our cutoff was 1.3 to demonstrate the benefit of target therapy, and however, in conclusion, only 9 patients of all the patients had a clinical benefit, corresponding to only 2.6% of the patients. So the question, next step, is that we have a small proportion of glioblastoma patients benefit from target therapy, and my opinion is that comprehensive NGS panel is not indicated for routine screening, while only in this moment only BRAF inhibitor efficacy in these patients. Lastly, meningioma. We know that meningioma have a lot of actionable alteration, and we have a lot of clinical trials studying new target therapy in this population. very important is this trial published some years ago on Journal Clinical Oncology, analyzing the efficacy of FATE inhibitor in meningioma patient with NF2 mutation, reporting an interesting and promising results with a progression-free survival at 6 months superior to the pre-specified statistical endpoint. And in the next months, I think in May, in Italy, we are going to start with the first phase 3 study, analyzing an anti-angiogenic treatment, in this case regorafenib versus local standard of care in about 100 patients with meningioma. And it will be the first study worldwide with randomization between regorafenib with the anti-angiogenic therapy and a local standard of care. And we are ready to start. And so, in conclusion, we can see that vorasidenib is the new standard of care for low-grade glioma. We have another target therapy demonstrating efficacy in other glioma, diffuse midline glioma. The next step is to evaluate this drug as first-line setting. BRAF and TRK inhibitors showed activity in glioma patients, but NTRK especially in pediatric population. I think that we need more data for analyze this drug in adult population. And moreover, we need more data also for the other targeted therapy, such as FGFR inhibitor, MET inhibitor. And so I think that I recommend to use this drug only in the context of a prospective or registry clinical trial. While another prominent field is meningioma, because we can have promising efficacy for new targeted therapy. So I concluded, and thank you for your attention. And if you have any question.
Thanks, Giuseppe, for a fantastic overview there of targeted therapies. What I might do is ask people to put some questions in the chat, and we might address those questions after Dr. Keane's presentation as well. We'll address questions to both speakers. So if I can ask you to stop sharing, and I'll ask Dr. Keane to start sharing her presentation. Dr. Lily Keane is a principal investigator from APC microbiome here in University College Cork. She studied originally in the Queen Mary University, and then did some time in Germany and at the Karolinska Institute in Stockholm, and has recently come back to Cork. So we're very excited to have her here to help further develop our neuro-oncology research, and we're looking forward to your talk, Lily. Thanks.
Yeah, and can you can see my slides?
Yeah.
Yeah. Okay, perfect. Thanks, Jack. So I'm going to talk to you a little bit today about targeting part of the tumor microenvironment in glioblastoma. I actually work on both pediatric and adult high-grade gliomas. Diffuse midline glioma that Giuseppe mentioned, and also glioblastoma. But as I said, for today, it'll be focused on glioblastoma. So as probably most of you on the call know, glioblastoma is the most common and aggressive primary brain tumor. It's about 3 cases out of every 100,000 per year. And although it can occur anywhere in the brain, it's most common in the cerebral hemispheres. And traditionally, it was classified based on histology, but more kind of in the last 10 years, we're going more towards molecular classification. with the IDH mutation being probably one of the most common ones. So normally glioblastoma is an IDH wild type. We'll come back to that later. And then the standard of care normally is resection, radiation and chemotherapy. So basically, I want to give a little bit of an overview about what's been kind of done in terms of targeting the big immune component of these brain tumors, tumor-associated macrophages. And then what I'll do is I'll talk a little bit about one story that I've been doing in my last postdoc at Karolinska, and just sort of giving a sort of an overview of where the field can go and if this is something we can still pursue as a potential therapy for glioblastoma patients. So tumor-associated macrophages, but in the actual brain tumor itself, this will consist of recruited peripheral monocyte-derived macrophages and then resident microglia, which are the immune cells of the brain. So collectively, they're referred to as TAMs. And one of the big problems in different types of tumors, including glioblastoma and also other types of gliomas like diffuse midline glioma, is these tumors are considered what we say immune cold. So what that means is you have often immunosuppressive TAMs, and you've very little infiltration of those cytotoxic T cells, which will be the ones that will kill the tumor cells. And this environment is normally really, it's an environment that doesn't promote immunotherapy treatment or other types of sort of immunotherapies. And this could be partially why these types of therapies haven't been so successful in high-grade gliomas, because you just don't have the right cells there in the right environment. So what we want to always aim to do from the immune component is to try and heat up those brain tumors in terms of getting more anti-tumor TAMs or depleting the TAMs, and also getting more attraction of these T cells into the brain so that things like immunotherapies or CAR T cell therapies could maybe have a chance to work. And that's sort of our aim when we come at this from a tumor microenvironment perspective in these brain tumors. So traditionally, I suppose the big thing that people have tried to do is deplete TAMs. So there's been sort of in the last, let's say, from kind of the mid 2015, for example, and upwards, it's been really trying to just use antibodies to deplete them, and then in that way say, okay, they're bad, and if they're doing something bad, we'll get rid of them. And then in more recent times, people have tried to maybe block their recruitment, and then there's been other strategies. So I'm going to give a little bit overview of each of these. So the first one, depletion. So in this is a paper from 2015 from Johanna Joyce's lab, and this caused a lot of excitement in the research community, because it showed that if you deplete TAMs, so this is with a CSF1R inhibitor, if you deplete them, then in mouse models, you had basically eradicated the tumor. So this was kind of shown in other papers with other types of inhibitors that could deplete the TAMs. So as a result, this actual CSF1R inhibitor went into a clinical trial, but it was extremely disappointing. So it was well tolerated, it was found to cross the blood-brain barrier, but it had no efficacy, basically. So this was very disappointing. People were, okay, again, this was something, they went back and tried to figure out why this was. And one of the reasons was if you left mice for longer, which sometimes is not doable for lots of reasons, but if they basically now took and treated and left the mice, then this tumor came back and rebounded due to resistance. And then another potential reason was all the studies done in depletion of TAMs were always done in the context of tumors that hadn't been, for example, the mice hadn't been irradiated or had been given chemotherapy, which is kind of a different situation to what's happening in the clinic. And I'll come back to that later on. So there were also studies to try and block, as I said, most of this was around CCL2, that's kind of a recruitment factor for macrophages, and these were also quite disappointing. And then in more recent years, there's been more about reprogramming, and some of these are currently in clinical trial for different types of brain tumors. And this may be a better strategy. So this would be more trying to disrupt different interactions between the tumor cells and the TAMs themselves, or potentially reprogramming the TAMs into a different phenotype other than that of it being immunosuppressive. So yeah, as I said, it was quite disappointing. So one place that the research field started to go now in more recent years is trying to not look at TAMs as a single population, but instead looking at them as what they are, which is basically a mixture of resident microglia and recruiting macrophages, which can behave extremely different. So to try and consider the heterogeneity of the pool of TAMs that are there. And this basically people started to identify markers that could be used to identify and decipher between the microglia and the macrophages, which before wasn't possible, and started to do single cell sequencing, and basically started to show that the function of these TAMs was very different in glioblastoma, and also that we may need to consider them as such, as different entities. So we then in my last group, we started to kind of get more interested in what these microglia and macrophages could be doing in the context of IDH wild type versus IDH mutant glioma. So obviously, as Giuseppe mentioned, the IDH1 is like a mutation that occurs more in low-grade gliomas. So obviously it is actually probably one of the best prognostic factors for someone with the glioma, with patients with mutation living a lot longer. So we wanted to see, okay, first of all, what is it? If we look at the component of microglia macrophages, within these types of glioma, what do we find? And what we saw straight away is that if you look at the IDH wild type glioblastoma, you have way more infiltration of these peripheral macrophages than you do in more low-grade gliomas. So this was quite striking and was something that had been seen also in the literature. And if we delved a little bit more into this, what was really, really apparent is that the infiltration of the macrophages also correlates negatively with survival. So here I'm showing a gene called ITGA4. This is basically a marker of macrophages in glioblastoma. And then if we looked across, I'm not going to show all the survival here, but if we looked across multiple other macrophage-specific markers, we saw they negatively correlated with the survival, whereas microglia-specific markers were positively correlated. So what this basically meant was IDH wild-type glioblastoma has much more infiltration of peripheral macrophages, and they seem to be really negative for the prognosis. So we started to think, what is actually attracting these macrophages, and can we maybe find a novel factor that's attracting the peripheral macrophages, and could we potentially block it? So we did some in vitro studies, and I'm going to just show you very briefly just one study we did. So we just looked at the recruitment of the macrophages in the context of IDH wild type or IDH mutant. So what we found is if you have microglia and you have IDH wild type glioma cells, then you get a lot more attraction of the macrophages compared to if you just have the glioma. And then we do not see this at all in IDH mutant. So here you see if you have IDH mutant cells with microglia, you have a even less attraction of the macrophages. So this is kind of going with our hypothesis that whatever's happening in this IDH wild type glioblastoma is leading to the attraction of the macrophages. That could be very negative then for the tumor, leading to growth of the tumor, etc. So we wanted to tease this out a bit more. So what we did is we basically put in co-culture our glioma and our microglia, and then we either took the glioma and see if these primed glioma could recruit the macrophages, and we didn't see this in either case. But if we did this with microglia, but now primed with the tumor, we saw a really big attraction. So what this basically meant was, once the microglia are put in context with these IDH wild-type glioma, they will then secrete factors that seem to recruit the macrophages, rather than the glioma themselves being activated by the microglia, if that makes sense. So we did some RNA sequencing. So we basically looked now if we have our microglia exposed to IDH mutant or IDH wild type, and we found basically we did some analysis, and we came up with some candidate factors that could be important for the recruitment of the tumor cells by looking at what was different between the two cell lines. And then what we did is we basically knocked down these factors within the microglia, and then we see if we could actually then reverse the attraction of the macrophages. And we did this for the 3 candidate factors that we had, with varying results. So the strongest was actually if we knocked down MMP14 in the microglia. This led to kind of the most robust difference in attracting the macrophages. So that was very quite interesting. And then basically the next thing we did is we went back and just looked at the survival, within kind of all glioma. We looked at these factors to see if they were also negatively correlated with survival when they're highly expressed. And we saw that for all 3 factors, which would go with the idea that these are important factors for recruiting the macrophages into the brain, and then that these macrophages are negative for the tumor. So to kind of just summarize this part, I suppose my main point is, we need to start looking, more at the heterogeneity of not only the TAMs, but I think the immune cells in general in these tumors, to try and understand more about their individual functions. And of course, it is obviously an added layer of complexity that we have, also then, of course, the heterogeneity of different types of tumors themselves. So what we found was, if we have an IDH mutant, we have microglia with very little macrophage infiltration, compared if we have an IDH wild type. And what we see is that, these gliomas, which are IDH wild type, they activate microglia in a really different way to mutant gliomas. And as a result, the microglia are the ones secreting the factors that are leading to the recruitment of the macrophages. So at the moment, we're doing some mouse studies to see if we can, between IDH wild type and mutant, and we will see if we can then actually physically, or at least within these mouse studies, if we can block recruitment of these macrophages through inhibitors of MMP14. But we kind of are going towards, that the microglia would be, at least in the context of IDH mutant, kind of anti-tumoral, and that within the IDH glioma, they become more, pro-tumoral, but more towards the recruitment of the macrophages that then are the ones that are pushing the growth of the tumor. And just kind of in a future perspective, I mean, obviously now, we have, when we come to the classification of gliomas, we have, obviously histology, we have molecular characteristics, and we would, I suppose, argue that we need to go also more towards, understanding more about the tumor microenvironment and how that can inform us potentially on treatments that may or may not work. And, for example, I think in the IDH wild type scenario, depleting all of these TAMs, maybe isn't beneficial, whereas maybe just targeting the macrophages or targeting particular factors would be more beneficial. So how can we further stratify, I suppose, these patients based on what we can learn from the tumor microenvironment? And then, of course, I think the other thing which we're not doing, and it's not a criticism of the research field, but it's just something that can be very difficult, I think, in the research field, is we're often testing these immunotherapies, in the context of not having radiation of chemotherapy. And of course, that can have a big effect on what we're testing. And I think we need to kind of become better at modeling, you know, a bit more. We need to model better the clinical, what's happening in the clinic, you know, when we're testing these targets or testing these factors, in order to have a better translation, because just traditionally we're not managing to translate from the mouse to the human. And I think also going towards more sort of organoid, human organoids, things like that, I think will be sort of beneficial in the future. And then sort of bringing more the element of the radiation and chemotherapy, you know, into that will hopefully lead to also better translation. So yeah, so that's it. I just want to, you know, this is actually a lot of work that came from when I was at Karolinska. So we had a lot of great support there. And these are just the funders. So with that, I'd like to say thank you, and yeah, happy to take questions as well.
That's fantastic. Thanks so much. I might go first to the first question in the chat, which is directed to Giuseppe, and let me give you a chance to catch your breath after that talk, which was great. But Giuseppe, from a question from Andrew Lindsay, what do you think is the main cause for the poor response to targeted therapies? The blood-brain barrier, tumor heterogeneity, or other factors, I suppose?
Yeah, that's a great question, because I think that all of these causes are important for the poor response in glioblastoma patients to target therapy. But I think that in particular, the main cause is the high heterogeneity in this disease. We can have high heterogeneity between patients, so intra-heterogeneity, but we have inter-heterogeneity, and so intra and inter-heterogeneity, but also longitudinal heterogeneity. We know that some alterations can change in recurrent disease. And so I think that we need to perform a biopsy in recurrent patients when it is possible, because we can have different molecular alterations between diagnosis and recurrence. And however, I think that the single target therapy is not enough for glioblastoma. I think that the measure efficacy could be using a combination of target therapy and chemotherapy, I think. But we need a prospective trial or registry to confirm that.
Thanks. And can I ask you as well, you in your slides, you highlighted, the 50% clinical deterioration in patients who had NGS before they started targeted therapy. What's your kind of current practice for sending samples for NGS? Is it in patients who are doing well, or patients who are doing poorly?
Yeah, it's an important point, because we have a very aggressive disease, and so if we have NGS analysis when the disease is in recurrent phase, maybe it's too late to start target therapy. But in other way, we have a population that target therapy is not so efficacy, and so only for specific treatment like BRAF inhibitor and TRK inhibitor at this moment. And so I think that we could use a comprehensive NGS analysis only in the context of clinical trial, but use a specific analysis, for example, BRAF alteration by immunohistochemistry, for example, in all glioma patients, because we have a very efficacy treatment in case of the presence of this mutation.
Great. Thanks. Yeah, I don't think there's an easy answer for that question. It's it does depend on the clinical context. A question for Lily in the chat. You mentioned at the end of your talk about developing better models, and what would these be?
Yeah, I mean, I think the big thing is to try and go more towards humanized brain organoids would be something I think it could be particularly good. So obviously you can try to develop that, I think, from a resected tumor, and then just being able to maybe use potentially, now we're quite reliant on, for example, primary cells from mice and things like that, but more going towards then iPSC derived, maybe immune cells. I just think we need to go more towards these humanized models, because the problem, I think, with the mouse models is they're just not, we're not that translatable. That's just the way it has been. And then I think we're not, trying to do what we're doing, and then also maybe have radiation and chemotherapy to have it more relevant. It's very difficult to do. So I think we have more scope going towards the humanized, is kind of my feeling. Yeah.
Yeah, and I think certainly the more kind of patient samples and things that we could analyze for, the kind of human context. You eloquently said about how the microglia were very context driven, in their so I think it is important to analyze these in a patient population after prior treatments. So
yeah, definitely.
We'll have further conversations about that, Lily.
Yeah. Yeah.
I don't see any other questions in the chat. So we might wrap it up there a couple of minutes early. I want to really thank our two speakers for really interesting talks. It's great to have neuro-oncology researchers presenting and putting this type of research back on the agenda here. The next Cancer Seminar Series is on May 13th. That'll be chaired by Dr. Owen Malloy, has a more hematology focus with speakers Dr. Lucy Norris and Dr. Maeve Crowley, speaking on cancer-associated thrombosis predominantly. So thanks everyone for attending, and we'll wrap it up there.
Thank you. Bye.
Thank you. Bye-bye.
Bye. Thanks.
Thank you. Thank you, Jack.